everybody. Happy to chair this amazing session. This promises us to show very interesting case and discuss more about shockwave technology and how we can crack the calcium during our procedures. So I give the podium immediately to Giacomo Isernia for his presentation. So how is IVL changing the game in iliac calcification? Thank you, Giacomo.
Thank you. Dear colleagues, moderator, I'll try to explain in the next 5 minutes how IVL is now changing our daily practice when we face with calcified vascular accesses. This is my disclosure. This is a case of 85-year-old male patient with a CLTI affected by rest pain. The patient presented a common atherosclerotic burden, and in particular, an occlusive disease was associated also to a small infrarenal abdominal aortic aneurysm, measured 32 millimeters. According to the well-known Task 2 classification system, this patient was considered a Task D lesion. Going deep with the vascular disease, he presented a left occluded iliac axis with just a small amount of circumferential calcification. But on the right side, we faced with a tight and extensive rock of calcium, in particular in the external iliac artery, with a minimum lumen of 3 millimeters. We scheduled this patient for a CRAB procedure. Aiming to classify vascular accesses for endograft delivery, a recent published article from my colleagues and friend Fazzini and Bossier filled the gap with the calcified access severity score. When the score is equal or plus to 10, there is a recommendation for IVL as a first-line strategy for endograft delivery. After evaluating the calcium score, the length, the tortuosity index, the stent graft index, and the minimum luminal diameter, we obtain a score more than the fixed threshold of 10, is 14, so finally indicated the use as a first-line strategy of IVL technology for this specific patient. Following the indication of the master of CRAB, we treated also the outflow with a left common femoral artery endarterectomy, improving the distal runoff in the profunda artery. We started the procedure applying IVL technology with the M5 Plus catheter, 80 millimeter by 60 in all the length of the external iliac artery, spending in total 6 cycles of the catheter to prepare this vessel. We treated also the proximal common femoral artery with the same balloon, with a complete balloon expansion, with a very nice angio result, an impressive luminal gain, and no sign of dissection after IVL. The procedure proceeds with an up-and-over approach from right to left and a recanalization with a coaxial technique with a 4 French catheter and an 018 supportive navicross inside the occluded axis in order to re-enter just at the level of the common femoral artery that is already exposed and repaired with the patch. At this moment, we easily establish a true-and-true femoral-femoral guidewire system in order to advance from both sides of the catheter and to re-enter inside the lumen of the aorta and having 2 guide wires from one of each side. We need to predilate with a 4 millimeter long balloon all the left external and common iliac artery in order to advance our material. We was able to advance and deploy a proximal aortic cuff with an 18 French delivery system, selecting the best solution for the patient from my side, just considering the vascular anatomy and with no limitation in material selection due to the calcified access. We decided the specific graft for this patient. This is a comparison on the right side between just IVL and after the cuff delivery and positioning. We evaluated just a small dissection of the external iliac artery after the endograft passage. We completed the procedure as a CRAB technique deserves, using a self-expandable proximal aortic cuff, we avoided the well-known possible side effect called toothpaste reaction, to avoiding a possible squeeze of a thrombus inside the left renal artery that is partially involved of a thrombotic material just around the aorta at that level. And we complete the procedure positioning 2 VBX at the aortic bifurcation. We again check that previous small dissection at the level of the right axis after the advantage of the proximal cuff, and we decided to overstand that, of course, to improve the outcome of the patient. And thanks to the previous vessel preparation with IVL, the stent graft, that is a bare metal stent, 8x60, was perfectly expanded and dilated. And now the completion geography show a very nice result, a complete reconstitution of both iliac axes and a brisk flow inside the limb. Dear colleagues, to conclude, please do not accept any kind of compromise in endograft selection, and when you see calcium in your vascular axes, think IVL as a first-line strategy for our patient. Thank you for the attention.
Thank you, Giacomo. Very complex case. Congratulations. Now I'm called Marc Sirvent. How can IVL maintain options in patients with femoral popliteal disease? Please, Marc.
Okay. Thank you very much to Shockwave for this invitation. It's a pleasure for me. So these are my disclosures. As you know, the FemPop segment is a very complex segment for endovascular treatment. Due to the forces appear at the same time in this area. Especially in the popliteal area, when the patient bends the knee, we can find these situations. Even further, if we face calcified lesions, this is the topic today, we can have more frequently vessel recoil, dissections, perforations, under expansion of the stents, and of course, the drug uptake is limited. Here is a clear example of what we can find using stents in this area. These 3 fractures matching the 3 flex points when the patient bends the knee. For this reason, in my FemPop algorithm, the main way is the drug-coating balloon way. But the important thing here is everything depends on the result of the vessel prep. This is a key point. Talking about calcified lesions, which is the topic today, the only way, in my opinion, to use with good results the DCB is preparing the vessel using debulking devices or IVL. Comparing IVL versus atherectomy, we can say that atherectomy may provide benefits in long CTO, not in clinical terms, but maybe in cost, because in this kind of lesions, maybe we could use different Shockwave catheters. And of course, in those lesions where the IVL is not indicated as in sternal stenosis. But atherectomy has several limitations. Has a steep learning curve, higher complication rate, only modifies intimal calcium. We cannot use in subintimal approaches, at least on label. It's time-consumer procedure, and we require additional equipment. Whereas IVL has a short learning curve, facilitates a quicker procedure, needs fewer adjunctive tools, modifies intimal and subintimal medial calcium, is supported by robust data. Here on this slide, you can see how exceptional is the safety profile of this device, and very effective in such complex lesions. Compared to PTA, we can reduce using IVL a lot the need for below stenting. preserving future treatment options and achieving a very good results in these complex lesions. Let me share this clinical case. This is a disabling claudication, multiple cardiovascular risk factors, 2 renal transplantations in waiting list for a third. This is a basal angio, CO2 angio, where you can see a calcified occlusion and a significant disease in the SFA. We tried to recanalize intraluminal using a CTO guide wire, but we couldn't. We exchanged the guide wire using a narrow loop to recanalize. This is the outflow. You can see the TOTH lesion in the TPT. The main outflow is the PT artery. We predilate this lesion using a semi-compliant balloon in order to prevent any damage in the balloon, in the Shockwave balloon. Several cycles of Shockwave until we wound the lesion. This is the vessel preparation result after Shockwave. And the final result after DCB, long DCB, is here, without dissection, without complications, no embolization in the outflow. The patient remains asymptomatic since 6 months later. And to conclude, ladies and gentlemen, using appropriate tools for vessel prep, you can avoid placing a stent in many cases, even in calcified lesions. IVL is a powerful tool for treating calcium, superficial and deep. It's easy to use, has a very low rate of complication and excellent results in all types of calcified lesions. And IVL significantly reduces the need for below stentings, preserving future treatment options. Thank you very much for your attention.
Thank you, Mark. Now it's time for Dr. Ashish Patel from London. How is IVL best utilized to improve outcomes in patients with CLI-TI?
Thank you very much, Maria, and Shockwave for the kind invitation. Hopefully in the next few minutes, I'll give you an idea of why and when I use IVL for treating patients with CLTI. What is the problem with patients with CLTI? Well, firstly, we know that they have a systemic arterial calcium burden. These patients have multi-level disease, and there's clear evidence now these vessels are more calcified than non-CLTI patients. And calcification is directly linked to worse outcomes in these CLTI patients. And there are studies that have shown that patients with calcified tibial arteries have a higher risk of amputation than those without calcified tibial arteries. So the problem with CLTI patients is that they only get one chance. We have to get this right the first time round, and failure is not an option. So what are the risks of treating calcified lesions in our CLTI patients? The first and obvious risk is dissections. These patients have a high calcium burden, and we know that severe dissections are directly linked to a higher risk of major adverse limb events. There is also a risk of distal embolization in patients who already have poor runoff when we treat these patients. So what we need is a device that has very low embolization rates. These patients often require stents, and calcified lesions, there's a higher risk of stent fracture and reduced patency rates. And we all know that on table, there is a really high risk of vessel recoil in unprepared calcified vessels, because these vessels are not compliant enough. And most importantly, the use of DCBs. In these patients where there is no access to the media, these DCBs don't have much effect. And we know we need to reduce restenosis in these patients. So I'll show you a few cases now. In this example, a 66-year-old patient with multiple comorbidities on dialysis with very calcified vessels. But the main issue here is that they have single vessel runoff. The key plan here was not to lose this patient's only vessel runoff. There's a calcified lesion at the top, as you can see, and then a bit distally as well. And on the angiogram, you can see the calcified vessels on the X-ray, but also an SFA origin lesion and the one at the adductor canal with very poor runoff. So my strategy in these types of patients is to use an appropriately sized balloon. So here is an 8mm Shockwave catheter balloon, and you can see the device there, followed by an appropriately sized POBA and then DCB. But just before this, there was another lesion distally. And so again, a separate balloon in this case, as I had to use all the shots on the proximal lesion. Again, a 7mm Shockwave balloon, appropriately sized based on IVUS in this case, followed by plain old balloon angioplasty and then a DCB. And in this situation, there was good luminal gain with no loss of the runoff, and that patient did really well. We also know that patients with below-the-knee disease have very calcified vessels, and this is an area that we are really struggling with. A 64-year-old patient who already had an amputation at St. Elsewhere with multiple comorbidities, but now has a non-healing wound. And you can see on the angiogram there is one vessel runoff in a way, the AT, which is heavily calcified, and the IVUS pullback here that I've done shows that this patient has the typical medial Monkenberg sclerotic type disease, medial calcium, and there is no device that accesses the media as well as IVL does. So it's quite straightforward to treat the top of the AT with a high-pressure non-compliant balloon, but you can see distally there is immediate recoil after treating that distal DP, and this is where these patients do badly, on-table failure and early limb loss. And you can see the calcium burden just on the plain X-ray. So in this situation, we've gone in with a Shockwave catheter in order to prep this vessel, improve the compliance, and then allow your non-compliant or compliant balloons to then have their effect as the vessel is much more compliant for angioplasty after. This patient is quite a recent case, and at the end of this case, there was no recoil, and the wound is healing very nicely. We also know that CLTI patients have multi-level disease. This is a lady with tissue loss, as you can see, 71 years old, with multiple comorbidities, but the main problem here, as well as having a short-ish CTO, she has a very small SFA. On the CT scan, it measured 3 to 4 millimeters. This is the situation where stents don't do very well in our experience. So for this case, you can see that the calcium burden on the reconstruction. So she underwent a femoral endarterectomy first off for the inflow, and you can see the short occlusion here. So that was crossed, but you can see the runoff. She has all the problems with CLTI that we see: multi-level disease, calcified vessels, and single vessel runoff or poor runoff. So once we've crossed this lesion, using an appropriately sized balloon, again here you can see it's only a 5mm balloon. I showed a 4mm SFA on IVUS, followed by POBA and a DCB. And you can see here how the CTO has opened up very nicely, and her runoff is preserved. What was really interesting was looking at the IVUS images before and after. Her vessel measured 4 millimeters at best beforehand, and after IVL and angioplasty, it had dilated, it was much more compliant, and now was measuring up to 6 millimeters. And finally, we also have a cohort of patients who are frail, elderly, and we often operate on them for quality of life. Some of these patients are not going to live very long, but they are in real trouble, and we have to offer them something. And often it's not primary amputation. And in this case, this 85-year-old patient had quite severe common femoral artery disease, calcified vessel, but would only tolerate a local anesthetic procedure. So you can see here we've gone up and over, stented the iliac artery, and then used IVL to treat the femoral artery, post-dilated it, and he's done really well and is now happy with a much better quality of life. So just to conclude my final 2 slides, so the key message here is that IVL is consistent across multiple vessel beds, and our patients have multi-level disease. It's consistent across CLI patients, eccentric lesions, and patients on dialysis as well. Again, our patient cohort. So to conclude, IVL is a good tool for multi-level disease, often with patients who have very poor runoff. We know these patients have a high risk of early recoil, on-table, or restenosis, and we have to use a treatment modality to prevent this. IVL, in my hands, improves vessel compliance across all vessel beds, and it especially allows access to the media of these vessels so that our DCBs can actually have effect. So hopefully I've convinced you that IVL is safe and effective in CLTI patients where treatment failure is not an option. Thank you very much.
So, Antonella, waiting some question from the floor, I would start asking Giacomo something. So congratulations for your complex case. Is the case that is in the middle between an aortic disease, a peripheral disease, and aortic occlusive disease, in which you combine all a new technology such as IVL, something that you know, such as a cuff, so an aortic endograft, and of course, curved stent. You flare this stent. So, of course, you did also an hybrid procedure with a common femoral endo repair. In your eyes, there is still room for open surgery, so open conduit or endoconduit that in many cases is a risk for hypogastric coverage. What do you think?
Thank you for the question. Of course, speaking about endograft delivery, and in particular considering a complex aortic repair when we face with large bore accesses, more than 20 French, but sometimes we need also introducer sheet of 24 French. When we face calcified access, and in particular when also we want to modify compliance in order to improve rotation and the manipulation of the system inside all the iliac accesses, for us now IVL is the first line strategy. Remain an indication for surgical conduit when you face, for example, tiny and narrow but not calcified accesses for a young lady or from a lady of 4 or 5 millimeter. In that case, probably having a surgical conduit is better than have a bleeding during the endograft delivery.
So you agree that it's better to place a stent after the endograft delivery, so never before. So prep the vessel prep by IVL, deliver the graft, and then eventually stent the external if you need it.
Definitely, okay? Yes. Also, if we have a very nice access in terms of sites, 6, 7, 8 millimeter, but several calcification and circumferential calcification, applying the IVL will allow us to improve endograft delivery and eventually put a stent after the removing of the sheath, because sometimes we also could save the hypogastric artery that is necessary to sacrifice when you perform an endovascular conduit for your endograft delivery.
And it's very important to reduce also the risk of spinal cord ischemia, and it's very important to avoid stent to manipulate, to allow a twisting in case of beaver fever, for example. Please, Antonella.
Yeah. Actually, I have a question for Mark. And we know that the results from DisruptPath 3, they are very promising in terms of safety and efficacy, but you know, what is reported in the papers not always reflect real life and real practice in our cath lab. So what is this data, do they match your personal experience?
Yeah. In my experience, is perfectly matched, because as I present, the IVL results is consistent in all scenarios, in different vessel beds in different lesions. So in my daily practice, I consider the results in CLTI, in diabetics, and I have very good results in every scenario. Yeah.
Thank you. And also, in the below the knee, we know below the knee vessels in a CLI patient, they are always let's say, the limit that we need to overcome. What IVL really is a change in your practice? Is it very important, the ability of IVL to really deal with those kind of lesion and this kind of patient? It's really a game changer.
Yeah, good question. I think one of our real challenges for CLTI is the below the knee problems in other cases. And in the calcified vessels, you see early recoil straight away, and the technical failure on table is a real problem. So we certainly do see that changing the compliance of these tibial vessels really allows for the high pressure non-compliant balloons to then really work and create luminal gain. And we know that luminal gain correlates with tissue healing as well. So I think at the moment this is the game changer for below the knee treatment. And time will tell whether or not access to the media of these vessels might allow DCBs to have more effect. I think we need some more data on that side.
So I'm learning if I see calcium, I think to IVL from iliac to the BTK. But the key point seems that the low barotrauma is, of course, something that causes so low complication, so low risk of dissection, low rate stenting rate, low rate of embolization. So in your ideas to Mark and Ash, I'm asking you, if I start to use IVL tomorrow, so which is the target lesion that probably could be the ideal to start in FEMPOP disease, for example?
I think one of the real beauties of IVL is a safety profile. It's not a balloon. It's a catheter that emits shockwaves, and essentially it is so safe that you can use it in any vessel segment with an incredibly low risk of dissection and no risk of perforation. So if I was starting off, I would say certainly for the SFA pop segment, it's a bit of a no-brainer, and certainly later on, I would go for the tibial vessels. But I don't know if you agree, Mark, but the FEMPOP segment seems quite sensible.
Yeah. Indeed, when I see calcium in my patients, I think quickly about IVL. And I use it in 80–90% of the cases. So the question maybe would be a reverse. So when don't use the IVL? So for me, in those cases where I have to perform aggressive subintimal approach to recanalize, because not due to the efficacy about the IVLs, but I know I need that there I will need to place a stent. So in those cases, I prepare the vessel using a non-compliant balloon just to create a channel to place radial super stent or Renzen stent. This is one case. And the other case maybe is in these focal lesions, eccentric lesions, cauliflower lesions. Maybe in those cases, I prefer the atherectomy.
Last quick question for Ash. In the last case, you showed the treatment with CFA. So it's something new, of course, in endo treatment, and in this case, IVL standalone treatment probably. So which is your opinion in the next future? Probably we'll have the L6, so the better sizing for CFA. Which is your opinion?
As a surgeon, I still think femoral endarterectomy is a good operation, but there is a cohort of patients who simply can't have it, who are too frail, and we end up using IVL. And we are doing that more and more. Patients where you're staying above the profunda, possibly, and hopefully not stenting. I think with the bigger devices as well, there'll be more and more use cases.
Thank you. Time to wrap up. Thank you for all the speakers for the amazing presentation, and thank you all for joining us for this lunch symposium. Thank you.
Thank you.